I will talk about the issue of health inequalities and try to convey the message that this is becoming kind of a hot topic, even in the biomedical field. We tend to be very narrow-minded people. We are concerned about, molecules, cells. But I will try to prove to you that we are widening our horizon in terms of determinants of health. So that's the kind of message I will try to convey tonight. So just some definitions, what we mean for health inequalities, and also some differences between inequalities and inequities. So inequalities generally refer to differences in the health status of individuals and groups, and these differences may range from biology, genetics, to broad social and economic factors. Health inequities refers to health inequalities that are generally considered to be unfair or unjust and modifiable. This is the definition from the Public Health Agency of Canada. And another definition from WHO around health inequities as systematic differences in health status or in distribution of health resources between different population groups arising from the social conditions. And I think this is important, social conditions in which people are born, grow, live, work, and age. So you see there is no reference to genetics, but the emphasis is on social conditions. And so when we talk about equity as a normative, again, we need to look at how can we avoid these unfair or unjust differences among individuals and also among population subgroups. So the issue of health equity has been, again, set by the Public Health Agency of Canada as the absence of unfair systems and policies that cause health inequalities. Health equity seeks to reduce inequalities and to increase access to opportunities and conditions conducive to health for all. Now, why we have health inequalities around the world, I mean, locally, nationally, and internationally? Well, we have inequalities because we make bad decisions in terms of social policies, in terms of economic arrangements, in terms of bad politics in general. And this actually is the former director, General Director WHO, the World Health Organization, and Margaret Chan is actually a graduate, was a former graduate in medical school from Schulich, and we had the pleasure to have her here a few years ago. And again, she was talking about health inequalities with emphasis on the social environment that determine access to health services and influence lifestyle choices in the first place. And there have been many other quotes around the issue of health inequalities, and Martin Luther King, all the forms of inequality, injustice in health care is the most shocking and inhumane. So are there healthcare inequalities in Canada? Yes, there are. And for example, if we look at differences across income groups in Canada, we know that people living in the poorest quintile of income are less likely to use cancer screening services, have fewer specialist visits, longer waiting times, higher rates of emergency hospitalizations, avoidable death hospitalizations from ambulatory care sensitive conditions. So there are many mechanisms whereby we have inequalities in Canada. And if you look at, for example, the expected years of life in full health of Canada, again, there is a huge difference between the poorest quintile of income and the richest quintile. So we're talking about over 10 years of life in full health in Canada as well. So the role of social determinants of health is predominant and is prominent in terms of making Canadians sick. So when we look at the global burden of disease in Canada, you see that over 50% comes from life circumstances. And these are all social determinants of health. For example, the role of biology, genetics and biology is only 15%. But even if you think in terms of investments, both in the biomedical field, in research, most of the investments still obviously try to focus on biology, genetics, and there is a neglect of the social determinants of health. So what causes health inequalities? There are many layers whereby health inequalities are created throughout the lifespan. And they go from individual level risk factors to social community networks and more generally to the broader environment. And again, there is a system map of the causes of health inequalities, which goes from, if you like, physiological and health behavioral risk factors to psychosocial factors like social isolation, social support, social networks, to wider determinants of health, as we mentioned earlier. Obviously, there are population subgroups who suffer from health inequalities. We talk about the issue of indigenous groups here in Canada and also in other countries. And you see there are different factors or mechanisms whereby indigenous people have a much lower, for example, life expectancy, and in general they have worse health outcomes via proximal factors, intermediate factors concerning access, for example, to healthcare system, or distal factors, colonialism, racism, and social exclusion and self-determination. But there are many other population subgroups who are marginalized in Canada and also in other countries: new immigrants, refugees, people by sexual minorities, low socioeconomic status, people with disabilities, Katerina was talking about that, people with mental health problems, elderly, children, women, homeless, unemployed, and global communities in general. And when we look at the expenses in healthcare across the world, we'll see that basically there is a dramatic gradient whereby countries which will need health care expenses be higher actually are those who have lower resources to tackle some of these inequalities. So there are recommendations from the WHO, the World Health Organization, how we can tackle some of these health inequalities by improving daily living conditions, tackling the inequitable distribution of power, money, and resources, measuring and understand the problem, assess the impact of action, enhancing health promotion and disease prevention. Sorry. I'm going to, no. Oh, what's happening? Because I can only go forward, right? That's interesting. If we go back a few slides, James, please. Another one? Yes. So enhancing health promotion and disease prevention policies to meet the needs of disadvantaged populations and develop targeted intervention nationally and locally. Now, this all sounds very good, but obviously the implementation of these recommendations are extremely challenging. But there is an increasing recognition. United Nations, as you may know, set these sustainable development goals, and the emphasis really is on reducing health inequalities from no poverty, zero hunger, good health and well-being, quality education, gender equality, clean water and sanitation, and so on. And obviously, we also need to advocate for the public health sector, the public sector, which needs to be accountable. So we're talking about local governments and health commissioners as potential source of mitigators of inequalities or inequities. So develop, for example, equity monitoring and accountability system or incentivize pro-equity policies and practices. In terms of the role of social determinants of health and healthcare, health professionals, physicians, and other health professionals must understand the role of social determinants of health in individual and community health. We need to strive to implement public policies that reach the largest number of people while targeting day-to-day individual needs in communities. We need to increase awareness for the role of physicians, health professionals as an advocate for patients, and also try to push for health in all policies, approaches, which entail a collaborative approach that integrates health considerations into policy making across sectors to improve the health of all communities and people. The good news is that also medical journals, for example, this was an editorial in the British Medical Journal, are recognizing the immorality of inaction on inequality, and major bodies, for example, the American College of Physicians, published this position paper on the importance of addressing social determinants to improve patient care and promote health equity. These were keywords which were completely absent in the biomedical discourse until a few years ago. So I think there is good news that there is an increasing recognition that social determinants need to be part of the responsibility of medical care. So these are just the final quotes. The primary determinants of disease are mainly economic and social, therefore remedies must also be economic and social. This was from one of the prominent scholars in preventive medicine, public health, Jeffrey Rose. This is another statement from the Chief Public Health Officer of Canada. We cannot rate our collective health and well-being by looking only those who are the healthiest. We must also consider those left behind. And I think I'm done. Thank you.